Thank you so much. I know we've had a very informative morning already. So while I'm getting organized, we had questions that were submitted through the webinar, as well as those of you who've registered and sent your questions in online. But while I'm getting those organized, I'd like to just address all three of you. If you don't mind speaking to how you might work together as a team in the different specialties in the care and treatment decisions for patients.
Well, I'll start with that. We have a unique clinic where we get together our specialized medical and radiation oncology team and myself and one or two other surgeons get together every week and see patients together, where we come up with the best comprehensive plan for patients, and then we're in constant communication through the rest of their team members to treat patients every week. So that's the very basics of how we make those decisions. And obviously, every patient is unique, and so we think that seeing them all at one time is not only convenient, but it allows us to, in real time, talk about the unique aspects of the patient to formulate that unique treatment plan for them.
Definitely one of the frustrations we hear from patients who are newly diagnosed is, there are a lot of doctor's appointments, and sometimes it's hard for one particular doctor to make a treatment decision for the whole team. And so it's frustrating to see a doctor and then have them say, well, I have to talk to this other doctor and send you to see this other doctor. And so I think we try to cut through all of that by basically having a multidisciplinary clinic, as Dr. Olschlager said, where you actually get to see all the members of your team at once, so we can come up with a plan right then and there together for what to do. I think in the sort of potentially curative setting for stage 1 to 3 cancer, that tends to be how we prefer to see our patients, as a team together, so that we can come up with a unified plan. For patients who present more with metastatic cancer, their quarterback is really their medical oncologist, and so they're typically cared for primarily by that oncologist as they're going through the month or years of systemic therapy. And then we are also members of the team, and we will kind of chime in when our various services may be needed.
I don't think I have anything to add to that.
Okay, thank you. Could you address if there is a process for restaging patients after perhaps a first line or multiple treatments, either medically or surgically?
So there's CT scans I think they're the mainstay of how to evaluate things. Sometimes you do PET scans or other imaging. But so in the metastatic setting, usually you do about 2 months of chemotherapy, and then it's repeat imaging, and then that kind of just continues throughout. In the setting where you obviously need this, if you're going towards surgery and stuff, you can do the restage, you can get chemotherapy, do restagings to make sure nothing's gone worse. And I think especially in the settings where a cancer might be initially, what we'll say is locally advanced, so not spread, but something that's not upfront resectable, and you're giving chemotherapy, that's something where clearly you bring that imaging back to the multidisciplinary clinic, so you can get the surgeon, the radiation oncologist, to comment on how to add more to that therapy.
And similarly, if Dr. Olschlager, if you could address what are the chances of a recurrence of cancer after a total gastrectomy?
Well, the biggest driver of the chance of recurrence is the stage in which a patient presents. So obviously, the lower the stage, the better chance we have of curing it, the less chance of it coming back. And that can be, we can get up to 90+% chance of cure or less than 10% chance of recurrence for very, very early stage cancers, and that goes all the way out to let's say the patients with the highest stage that we'll treat surgically can unfortunately get down to 20-30% chances of cure, so they have a 70-80% chance of recurrence. So it's all depends there. And then I think, as both of my colleagues said in their talks, these are just medians, these are averages. Patients are individuals, and they generally have 100 or 0% chance of it coming back, because even in the realm of gastric cancer at any particular stage, we talk a lot about the biology of a certain patient's tumor. We don't know usually at the initial diagnosis. We don't know how that cancer is going to act uniquely different than the next person, but some act more aggressively than others, and that's really the biggest factor in whether it comes back or not.
Thank you. And Dr. Zhang, regarding recurrence or the requirement for multiple radiation treatments in the same area, could you address that briefly?
Sure. So I think especially for a cancer like stomach cancer, radiation is pretty much never used by itself to cure stomach cancer. We're always being used in conjunction with surgery, most likely, or, with at least chemotherapy. So I think typically, from a technical standpoint, is something doable? Can I radiate it? The answer is often yes, I can do it. I think the bigger question is, does it make sense to do it? Does it help? If I'm giving radiation treatment, usually the question I ask myself is, one, am I helping to cure your cancer? Or two, am I helping you feel better? And that would be the goal. And so while it is certainly possible sometimes to give radiation to the same spot a second time, or even very rarely a third time, the question is really, what are the side effects from that second round? Is it worth doing? Because what do we expect is the benefit of doing it?
Thank you. And if there's any questions in the room, Francesca is going to be walking around with a microphone, so if anyone in the room does have a question, please just raise your hand and she'll be by shortly. And while we're getting prepared for that, Dr. Schleicher, you mentioned the volume effect as it relates to surgical outcomes, and I'm curious, Dr. Kovler, if you have experienced some similarity in volume effect with non-surgical treatments, and that may be a similar question with radiation as well.
I think the data isn't as well published. I think surgeons have looked at clearly the volume numbers more than other people have. So I think the data is strong there. What you do get, it's kind of interesting. This you work with. I think it depends on what setting you're looking at. There are clearly people who do this more often know how to do what they do better. It's like anything else. So I think people who are giving the chemotherapy and just seeing one diagnosis know some of the treatments that are out faster. There are more guidelines, so there is a better way if people are up to date for oncologists who are out in the community to keep up with the chemotherapy. I think a big part of what we want to do is it's always good to get a second opinion somewhere where it's a high volume or someone who all they see is GI or all they see is stomach cancers for an opinion, and then seeing what it is that they think you can do locally. I think we're all really good in the Seattle area. There's all these people across the lake and stuff like that with travel. It's good to get the opinion, and I think we want to center your care where we could. We'd love to take care of everyone if we could. But, if you're not going to want to be driving 5 hours back and forth every 2 weeks for something that you frankly could get closer to home. At the same point, if we have the next treatment that we think is going to be the next best thing or a good trial that's specific for where you are in situation, it might be worth doing that extra travel. So I think, getting a good opinion, and oncologists usually aren't so egotistical that, we're like, oh, you can't go ask someone for another opinion. Anyone should really be supportive of those ideas. So I'm not sure there's, data saying, come here and it's going to be different. Where for surgery, you definitely need someone who does it enough. If I could say one thing to a lot of people who show up, it's like, you can go back and get your chemotherapy closer to home, but you need to be here to get your surgery or something like that. And
I think the strongest data is definitely with surgery, partly also because it's easiest to track. You have your surgery, and then we figure out what happens to you in the 1 month to 3 month after the surgery. Whereas with chemotherapy, systemic therapy, that's a many years long relationship often. And sometimes as patients are going through treatment, they can also transition from one location to another. And with radiation treatment, it's a several week treatment course as well. So it's much, and also that we give it with chemotherapy and sometimes surgery, so it's hard to figure out what is it that radiation by itself, does. I think there is some data that when patients are treated at these large academic kind of comprehensive cancer centers, so the kind of national cancer, network, they kind of designate what they call comprehensive cancer centers that really provide all the cancer-related treatments and services. And the outcome does seem better when you're treated at one of those. But I think when you're going through years of potential treatment, it is a very personal decision. Do you want to drive 3 hours, for your doctor's appointments, or do you want to drive 15 minutes? And there's definitely, we believe, value in being, closer to the comforts of home as well. And I think a lot of that depends really on what is your support network and what is your level of ability to be able to travel, and what does that mean to your life to have to go to a place. And so what we typically tell our patients is, if everyone lived across the street, that would be great, and we'd love to treat all of the patients. But otherwise, we try to say, are there clinical trials that you can only get with us, or can you get similar treatment closer to home? So I wish we had a simple answer, but it is a very personal decision.
Yeah, this is the most difficult question we deal with day in, day out, especially since we're in Seattle, uniquely geographically placed, so that there's like a big city and a otherwise very rural landmass in the United States. So we have a lot of people come hundreds of miles to see us, and they do usually come for surgery, as my colleagues have said. I have a unique perspective. Since I treat a lot of patients who get their chemotherapy or get radiation and are treated elsewhere in Montana and Alaska or somewhere else, I see it. It's hard to quantify, but I can tell you that many times I see and treat patients who they come back to me, or I hear about their treatment and something happens that someone just didn't pick up on when their course was not going the right way, and probably should have switched or probably should have done something in addition. And it affects often surgery and people's health. So I see it. So I know what happens, and I know it is potentially quantifiable. It's just difficult to study it. On the other hand, we're sympathetic. Being away from family, being away from and using resources that are often scarce for families is difficult in these, and that ends up impacting their care as well. So at the end of the day, obviously patients have to make an individual decision, and it's a tough one.
Thank you. We have a question from the audience.
Hi. Thanks for these presentations, which have been great. I had actually a question for Dr. Kovler. You mentioned a few targeted therapies, HER2 and perhaps the immunotherapies for MSI tumors. I guess I was wondering if you could just sort of comment on maybe what the standard of care is at UW in terms of tumor sequencing, and whether this is something that you encourage patients to do, or is it just more confusing, or?
Yeah, good question. So molecular sequencing, so this is mostly looking at the metastatic setting, so once cancer is spread. I think everyone is pretty much going to be getting MSI testing. Everyone pretty much should be getting, it's called a CPS score, which looks at how much immunosuppression there is in a simple way on someone's cancer. So those things can be done, should be done. Next-gen sequencing, or when you look at molecular profiling, the truth is you can do that now and get a lot more information in one test with less stuff. So from that perspective, it's the way I think most people are moving. When you get these from reports back, especially from like a company called Foundation One, you end up getting a list of all of the trials that in theory could be done. And a lot of that you can't actually do, either because of one, logistics, or two, because it's like this idea that doesn't actually pan out as well. So there's a little more hope there than there is current benefit. But at the moment, there's a drug that was just approved for tumors that have NTRK mutations. So we have NTRK, we have MSI, and these all sound like random little words, which is fine. But in the end, it's starting to get to the point where it's going to be simpler and better just to do one test that can give you this panel of like 300 genes than what currently happens is every time they're slicing a little more tissue out, is usually all we have initially in the setting is a biopsy. So there's this little bit of tissue sitting somewhere to do all the testing on. So I think more and more it's going to be moving towards a sequencing molecular profiling. Did that answer your question? Yeah.
And I think we have a couple more audience questions here.
Are there different treatments when you started out with being treated for HER2 positive, and then you find out you are no longer positive? You are now negative.
Mm-hmm.
Are there different options?
Yeah, so the people haven't in the past really been testing people initially and then again to see it. This was recently published when they're trying to figure out why all the HER2 subsequent treatments weren't working, and they learned that it's only about 25% of those initial people were remaining HER2 positive. But yeah, there's still the standard chemotherapy options. So really it's chemo plus Herceptin or trastuzumab when you can, and then in second line, there's still all the other chemo options. There's the ramucirumab, paclitaxel data would still be there. So there are still non-HER2 components to use.
I have really two points related. The one is I'm hearing that CAR T-cell therapy is working real wondrously, curing the metastatic cancers. And whether that CAR T-cell therapy is coming into solid tumors and stomach cancers. And another point is that the CAR T therapy, it costs $500,000. Mm-hmm. And I think we need to discuss this issue of cost problem. And I'm hearing that a lot of this new molecular therapy, targeted therapy, that costs $150,000 a year. Mm-hmm. In the past, people, even if the price of drug is high, people die after something like 2-3 months after taking medication. It doesn't really matter. Now there are new medication. People don't die. They survive a year, 2 years, 3 years. And this price issue, $150,000 a year, I think that will have to be addressed.
Yeah, so I think there were two questions there. So first, CAR T cells is the idea of, I talked about T cells fighting your cancer and using that if your immune system was able to see your cancer and then opening up that response. CAR T cells tries to get around the fact that if there is no response, can you just take a T cell and put in the thing that will target it right towards the cancer. CAR T cells really don't yet work in any solid tumors. They work in lymphomas and leukemias, which is two cancers where we know the immune system has been able to fight cancer before. Yeah, so they've tried some in pancreas cancer, and they've targeted some other things in lung cancer. And I don't want to say it's not going to work, because if you would have gone back, probably 5 years ago, there was all these people who were going to get immunotherapy to work, and then there's everyone else who laughed at all of them. And now at least they get to flip that, because they were right, immunotherapy can fight cancer. So I think you have to be able to find a target that works, and it has to be maintained. So I wouldn't write it off yet, but at the moment, T-cell therapy, or CAR T-cells for solid tumors is investigational and being worked on. Cost, which is what Untitled brought up, which I don't think I'm going to solve today, and is clearly a huge problem for how companies do it. It's what companies have started to do. As you look and they try and find bigger benefit in smaller populations, the companies at least argue, and I don't know how the math really works out, that, great, we're helping only 5% of the people, but it still took a lot of work. We did a study where we screened 10,000 people, we found 500 people, and we helped them a lot, and then they show you, well, we need to have enough money to make that a worthwhile investment. So there's clearly a cost analysis that needs to happen, and people need to figure out what the benefit is. So that's, I think, a large and complicated question that I'm in truth not an expert in, of how to drive that down. So clearly something to look at is we can't break the bank, which they're definitely trying to push it on to break it.
Thank you. I think we have time for just one more question, and this is regarding, we had 2 questions come in regarding HIPEC, actually, so I'd like to take a moment to address that. Could you discuss who is a candidate for total gastrectomy versus the HIPEC procedure and why?
I'll start, and I'll let you give your perspective. So HIPEC is essentially intraperitoneal chemotherapy. So is done usually by a surgeon trying to go in and take out all the cancer that they can, realizing that there's probably some left behind, and giving chemotherapy directly. Instead of infusing it into a vein, it's just splashed around the cavity, in most cases the abdominal cavity, and hoping to work directly on cancer. Probably the best results of that treatment are with primary peritoneal carcinomas. Probably next is maybe ovarian and some other things, and I'll let Dr. Kovler speak a little bit to that because it starts to get a little bit out of my expertise. It has been used in gastric cancer with some, I would call nearly antidotal or small case series with some occasional positive results. We generally, though, I think the standard of care is you look at peritoneal metastasis, which I talked about in my review, as being a sign of a systemic or metastatic disease. We usually treat that with systemic therapy, i.e. chemotherapy, with someone like Dr. Kovler, and not with HIPEC. And that would be sort of what I would say the standard of care. And then, when you have your standard, there's always the person that you treat outside the standard of care with HIPEC. It is it's very risky therapy. It's usually a big operation with lots of complications. And I would say the jury's still out on its benefit for gastric cancer, but that's my perspective.
So trying to figure out where to start. Okay, so if you think so usually where these are talked about using, it's really cytoreductive surgery plus HIPEC, which is this warm chemotherapy, as you mentioned, during the surgery. So, you start off, we're going to back up. When someone has stage 4 cancer that's spread, right, you're usually told it's not curable, and we're going to do chemotherapy. Though there's becoming, and there is more in some diseases than others, where there's a difference between metastatic disease, where you have, we'll say, 20 different spots where cancer is, and metastatic disease where you have 1 or 2. The truth is, unfortunately, most of the time, the 1 or 2 spots you also can't cure. But every once in a while, and the reason it looks so good is because you take the person who you said you're not curable, this person then is sitting in front of you, who's usually a younger person, and then is also usually doing better than average. So you're a year later, and they're like, I've been on chemotherapy for a year, I'm doing fantastic, and someone's like, should we go do the surgery? And then someone backs up and says, well, maybe we should do the surgery. So you're taking people who have already done better than general populations and saying, look how good this result is. But the result might have been good to begin with. So this is a couple years ago, there was a study, I think it was at MD Anderson, where what they were doing was for people who had cytology that was positive, a little bit of cancer in the abdominal cavity, they were doing these HIPECs to see if they cleared it, so there was no cancer they could find, and then they were proceeding with surgery. I haven't yet seen the data published to know whether that worked or didn't work yet. But it's a little bit of becoming more of a test of time, being if you were someone who, making it a little simpler, if you had 1 liver spot and we gave you chemo and it went away completely, and then you're off chemo because everything's so good and nothing's coming back, and then someone says, should I go get my primary stomach cancer taken out? And you're like, well, maybe you should. Maybe you're one of these rare people who we cured metastatic disease, and then you do it, and then you're saying, look how good the results are. it's a mix of biology, good teamwork, and things like that. So mostly not all that helpful as far as we know at the moment.
Okay, thank you so much. And I'd like to say, again, thank you to each of our presenters for their talks this morning, as well as responses to the Q&A panel. Thank you for joining us today.
Thank you.